You don't need.
I'm
sorry. Yeah, I think so.
What I see is online, because there is.
Where's John? He never comes.
I know. Exactly.
We actually, if you gotta talk, because we're trying to figure out a formal unity group. So I'm coming, so it's good, so come, good, good. Because his son is still like, there. Yeah,
Yeah.
yeah, son's, okay, so I'm wrong.
Yes.
I'm gonna John's water type thing. Okay, so I'm gonna.
Yeah, he's,
You're John or the son? John, oh. Oh, yes, they're, oh, that's probably.
He's gotten better.
Wow.
Hey, you guys, real quick, got some program information, some pins and post-its up here. Please feel free to take that if you like. There's also a sign-in sheet. If you don't mind, fill out as much as you're comfortable with, but if you don't need to put your name, we really appreciate it.
Okay, is it green light? Is all the audio and video good? Well, thank you guys for coming out to hear us. For those of you I haven't had a chance to meet yet, my name is Ward Blanchard. I'm CEO and one of the founders at the Blanchard Institute. We are a outpatient mental health and substance use disorder outpatient continuum that you'll get to hear more about. And I can tell you that when I walked in here, I told Charlotte, it almost felt like yesterday that I was in here having conversations with you guys. I think it was back in 2018-ish that we came and had this conversation with this group of independent physicians. And I can tell you it was one of the most valuable conversations. We do a lot of continuing medical education events where they're continuing medical education providers for Atrium and Novant, and a teaching site for them when it comes to substance use disorders and mental health. And so really would like this to be a conversation rather than me up here pontificating. Won't take you too long to figure out. I've never met a microphone I didn't like, but I really love the conversation and the interaction, especially around the topics of mental health and substance use disorders. And I actually prefer an intimate group. That this group is actually one of the groups that asked us for follow-up meetings, in their own practices, after this conversation, which we do free and voluntarily. And so I said, please, this is the time to ask your questions and provide your feedback, because we can tell we're passionate about working with professionals and helping communities with this condition. And so that's why the topic of the presentation is really about what I call new realities for families and professionals in the 21st century. And just the gross misunderstanding and misconception of what is substance use disorders, mental health, how to properly treat it, and how it shows up in you guys' offices. And the first thing I can tell you guys is the passion for this disease and for this treatment really comes from this really hit my family. I grew up one of those kids that you love to hate. It was almost like a Freddie Prinze Jr. movie is what I say. The homecoming king, the prom king, Valley Victorian. I actually grew up and never smoked, never did drugs, never had many mental health issues, but still by the time I was in college, still ended up strapped to a gurney in Wake Forest psych ward for 17 days. And when I ended up, finally getting help, it was, my family was blessed enough to have all the resources, in the world, and we still struggled to find appropriate help and appropriate access to, proper evidence-based care. And so when I got help, I really threw myself into this field to really understand what happened to me and really be able to help, other individuals and families. And I can tell you the most frustrating part as a, professional is, 17 years is the answer, but the question that comes along with that is, that's how long that it takes when you're talking about medical research and that goes through all the clinical trials and all its evidence-based peer-reviewed journal writing, that it takes 17 years for any type of treatment or any type of clinical research to translate to 51% of providers. It takes 17 years. That was an infamous healthcare article when I did my MBA in healthcare dissertation, that really 17 years, that when something is widely proven as the way to treat a certain healthcare condition, that it takes 17 years for 51% of providers to begin to utilize that in their practice. And if you were to ask me about the behavioral health industry, I would tell you that we are behind that we are probably 25 years behind. And when I go into treatment centers and resources, there and trust me, with behavioral health, any resource is better than nothing. And the curriculum and approaches they are using are 25 years behind. And can also tell you that most providers don't understand that we're one of the only parts of the healthcare system that lacks any sort of governing and regulation. You do not have to get approved by the North Carolina Medical Board to open up a treatment center. Anybody can. And so it's like the wild, wild west out there. And so that's why, educating providers about what we're going to talk about today is we're so passionate about, and why we really try to go out into the community and voluntarily go into groups to educate all the providers that it's going to take to help with this condition. And so we are going to talk about the solution, but before we talk about any solution, we need to first really understand the problem. And I know that when I used to ask this, I used to run this group out of the Betty Ford Center. They had a program called the SIMS program, the Summer Institute of Medical Students. And I'd ask everybody, even in the SIMS program and in their family program, how many of you guys think this is a disease? And of course, everybody would raise their hand. Say, how many of you guys are raising your hand because you look a jackass if you didn't? And half the hands would go down, even the providers. And it's said, okay, that's why we're here to talk about it. And so we're really here to really understand what that means when we talk about the disease. Because I can tell you one of the biggest gaps that I see in providing proper health care is we'll believe it's a disease, but even as providers, when it's time to treat it, we'll say things like you really have to want it to get better or have to hit rock bottom to get better, which are two categorically false statements. And if I spend the rest of my career trying to shoot down two statements, it's those two statements. We're going to talk about that later on, but we're going to first really try to understand that problem, and then some of the tools that you guys use. And especially if you are, in private practice in some sort of gateway to the sort of the healthcare world, that's really an opportunity to intervene, especially on the preventive side, to really catch it, earlier on before it gets to the late stages. And so to really understand the problem, we're going to take a look at a macro view, and all of us are well aware of the opioid epidemic. I'm not going to waste too much time. This is what I call a nation held hostage when it's talking about the opioid epidemic. In fact, when I was here a couple of years ago, it was education on the STOP Act. That STOP Act was the Strengthening Opioid and Prevention Act that tries to stave off, what level of prescriptions and how many prescriptions that providers can write. I was actually in here 6 months after it went active. I remember because I remember asking this, and nobody in the presentation had heard of it. And that was 6 months after it went active. And so it's what nation held hostage when it's coming time to the opioid epidemic. This is sort of a heat signature of what overdoses would like. And if I, had a current heat image, that whole, country would look red. And if we wanted to talk about locally, even the overdose deaths here locally have, skyrocketed from 45% in Georgia, 34% in the states around us, and North Carolina and even around Charlotte is actually one of the worst in the country. I was at a North Carolina Healthcare Summit in 2019 and heard the medical director of Blue Cross and Blue Shield and the CEOs of what the Montagues and the Capulets, Atrium and Novant, on a panel. And they said North Carolina had the highest rate of substance use disorder, the lowest rate of available resources of anywhere in the country. And even here locally, can tell you overdose deaths have increased in all 100 counties. That even in the 16 counties around Charlotte, enough prescription pain medicine is enough. 65 million narcotic pills were written. That's enough for every man, woman, and child to have 83 narcotic pills. This is a couple of years after the Stop Act. This is, back in 2014 is when our United States Surgeon General said we had the worst public health care crisis we'd ever seen. And we still have this, the issue that's happening. Even in North Carolina, 4 cities are in the top 20 in the nation. When we start talking about Wilmington, Hickory, Jacksonville, and Fayetteville, it's really because of where we are on the eastern seaboard, a combination of the traffic, our airport that's growing. I'm from the Outer Banks, and so you've got the inlets, and we called it midnight tuna when it came in on ships. And so North Carolina, this area is, one of the worst. And then even here in Charlotte, in a city full of 1 million people in Charlotte proper, enough, narcotic pills for every man, woman, and child to have, 37 pills. But a lot of times, even with the Stop Act, we hyper focus on this prescription and pain medicine. And yes, there needed to be some education and some limiting to it, but we also went, way too far to the extreme and just started focusing on just the prescription writing. I can tell you there's a much larger, problem going on here, because if we are to even think about, the overdose deaths, and I was actually in the room with 40 of us that were architects of that Stop Act, and I was there on the treatment aspect of it. And, the first stage of the Stop Act is really all that we've gotten to, which was, meant to target the prescription writing. And I was, there pounding the desk in the Attorney General's office. So you can stop that all you want, but the disease isn't going to go anywhere. And you've got to have treatment and resources. It's not the pain medicine that's causing it's the disease that's, causing the issue. Because there is a larger problem, because we are 4 to 5% of the global population and consume 90% of the world's pain medicine. And so there's something else that's going on, because we're not the only ones in pain. And even when it comes to understanding the nation's statistics, we're above most of the nation, even in our local communities. And so the ripple effects, show up in you guys' office. This chart, this visual is actually what I just said about the Stop Act. What you see here, those are lines of prescription writing that about in 2015-16 went down. Overdose deaths still skyrocketed, because the disease doesn't go anywhere. If you take away the prescriptions, the disease still flourishes and thrives. And without treatment, without proper, evidence-based resources for individuals and families, that the disease isn't going to go anywhere. And so that's what we've seen. In fact, when talking about this disease and just understanding mental health, despite what I say, being in the field of human services, that I don't walk around and meet one family that isn't directly impacted by mental health or substance use disorders in some format or another. In fact, 1 out of 4 adults struggles with some form of mental health condition. Depression, clinical depression, is the leading cause of medical disability worldwide. And we still struggle to understand and struggle to have, conversations about it, and how that has a ripple effect in our offices, between whether it's the parents that we see or the direct identified patients themselves, or the family members of somebody who's struggling. One thing we know, even if you're a family member of somebody who's struggling with any progressive disease, you are 5 times more likely to be in the hospital, just with that, caregiver stress and that, chronic stress. 25% of individuals that also have co-occurring disorders also have a substance use disorder. That's when they struggle with a mental health condition. 25%, at least 25% of people who struggle with a mental health issue also have, some form of substance use disorder. And 75, what we see, probably with primary substance use disorder, about 75% to 80% of our cases have both of those going on, co-occurring disorder. And I can tell you that when we took a poll of how many of those individuals actually got proper help, 90% of individuals with co-occurring disorders did not receive treatment for both. In my experience with the healthcare system, this is one of the most misunderstood parts of the entire healthcare system is the dual diagnosis, is how to treat, how to properly diagnose. And quite honestly, when I'm in a room full of psychiatrists, they'll admit it. They'll admit they do not know how to handle it. And when it comes to understanding, dual diagnosis, any form of mental health condition where you throw any form of a substance use disorder in there with it, they have no idea how to treat it and say 30 minutes once a month when the only self-report that you have is the person whose brain isn't working is grossly ineffective. And so all of this sort of compounds what trickles through our healthcare system and trickles through our offices. And even if we look at the ripple effect of all this and, what's happening in our society, 2017, 70,000 Americans died of overdoses. That's more Americans than died in the entire Vietnam War. And that's during the year that we all got targeted the opioid epidemic and created the STOP Act, and all the politicians banged the desk, and, we improved. But also people forgot that, 88,000 Americans died of alcohol related issues. And also in 2017, there was a coined term called death of despair was coined. And deaths of despair was a research done by Princeton. And deaths of despair are classified as alcohol related liver deaths, overdoses, and suicides. And those three deaths, that demographic went up in every state in the country in 2017. And so, you start to combine this with also in 2017, if you wanted to throw in illicit drugs, alcohol related deaths, and all deaths associated with some form of substances and addiction, the state of Vermont died in our country in 2017. And so there's actually something more going on here, because like I said, we banged the desk, we talked about it, and it dropped down. And for the first time in a decade, and any lives saved is a life earned, but we kind of forgot about it, and it popped right back up to 72,000. And I remember a local news article, the local TV stations call us every time there's any of these statistics come out or something and want to do an article. And I remember telling the reporter that it's just going to get worse. And she's like, how could it? I said, it's just going to get worse. We're not even the tip of the iceberg here. And in 2020, with these diseases of isolation, without the proper resources, what do you think happened in 2020 when COVID hit? Words like quarantine and isolation, and when we have biological needs to be safe, secure, connected to keep our brain heals. I can tell you here in Charlotte, 5150s and psychiatric holds. Psychiatric holds went up at the first 6 months in February to August to 2020, went up 257%. Alcohol sales went up 860% those first 6 months. And as you can tell, with by the time 2022 went around, we know that over 100,000 people died of opioid overdoses by that time. I mean, even in our 90-minute conversation here, you're going to have one North Carolinian, pass away. And so all of these statistics, even deaths of despair. And what we also know is happy people live longer. We know that even scientifically. In 2017, with all those suicide deaths and overdoses and alcohol-related liver deaths, for the first time in a century, life expectancy in the United States went down. And so there's something else that's going on here. A lot of times we want to point toward the rising demographic of, addiction and mental health, but there's something else, that's going on here. I tell people the chemical consumption is the easiest part to stop in our job. You know, if that's all we needed, prisons would work. They don't. And so there's really something else that's going on here. And so what's the real issue that actually really shows up in our offices through, you know, different ways, and what is it caused by is, you know, if you were to think about it, when you guys grew up, especially when I'm talking to this demographic, did you guys go to school with any active shooter training drills? You know, or, you know, we have 6 and 7 and 8 years old that are worried about what's happening in the Ukraine and Syria, and you know, the constant stress and constant trauma that is always at our fingertips and at their palms. And actually the physical impact that has on, you know, how they show up in their health and their well-being. But that constant stress, that constant trauma, and this slide was actually created before COVID. You know, this presentation, I did this presentation in 2019, about 6 months before COVID, and actually a neuropsych in the UN asked us to come up to New York to do it, because, you know, what I call mental health and substance use disorders, that equal opportunity destroyer that really has impacted all around the world. But the stress and trauma that we all feel, that idea that we live in a world that exhaustion is a status symbol. I mean, I feel the same way. I want to drive down my neighborhood after work, whenever that is, and pull in my driveway, pull in the garage, shut it behind me, because hell, if I want to say hey to the neighbor walking his dog, so I'm just too tired for this shit. I'm exhausted. You know, we use that as sort of a status symbol, but also the general lack of community that we have. You know, I grew up on the Outer Banks in a small island, but also LA and New York, and you can always find sort of community, but gone are the days of front porches, you know, gone are the days of sort of community engagement. And this isn't psychology and psychobabble, this is biology. We need community to survive, to be healthy, and we've lost that, and that just compounds the problem. And technology, I could spend a 5-day workshop talking about technology, and don't get me wrong, technology is tremendously, you know, healthy and beneficial and advancing, but we are the most connected, disconnected society ever. And how much, you know, what does this look like family time to all of us? I mean, how many of each of us, you know, text family members in the same house, you know, in the same room, even across the same dinner table? And when we have something really difficult to say, you know, we'll type a novella on text, and we'll say because it's convenient. But if we're really emotionally honest, it's because we're too uncomfortable to have that conversation face to face. It's like we've lost the ability to have what I call those crucial conversations from emotionally connected places. And even at providers, we've lost our way from that. You know, we talk to providers and talk to therapists about, even as providers, where we're supposed to have those kind, candor conversations, and we've gotten away from that. You know, we've gotten more into customer service than we have those crucial conversations. Like, being nice kills people. And it doesn't mean you can't be kind, but I tell people, and it doesn't mean take the cotton out of your ears and put it in your mouth and just shut up. I don't believe in punishment or tough love. You know, I don't believe in any of that. You know, but truth without kindness doesn't mean you're being honest. It means you're being an asshole. You know, but you still need to have those crucial, we've gotten away from it. You know, parents don't even know how to have those conversations with their own kids. And so that's how, you know, text message and email are rational forms of communication, never meant for emotional subjects. You know, I tell our staff, if families are well educated, not to send this stuff, you don't even have to read it. You know, but we've lost that ability to even communicate and connect. And just the impact of social media, I don't think it's remarkable to anybody, since social media came out on the palm of your hand. Suicides in adolescent females has gone up 150%. And just that, the impact that has, not only on the child, but on the parents, you know, what that profound and chronic stress. We wonder why we're raising a generation that is emotionally immature, when we have the generation that's raising them. The current American adult cohort is the most addicted, obese, medicated, in debt adult society ever. And so if you think about it, even what are those behaviors? If you were to think about it from
I thought you forgot one word.
Yeah.
Sociopathic also.
Say what?
I thought you forgot a word there, sociopathic thing.
Yeah. What are those behaviors when you know, those sociopathic, they're all external medicators used to treat something, and they're all dopamine driven sort of instant gratification behaviors. Like I said, we're wondering why we're raising a generation that is emotionally mature. Their parents who are exhausted aren't even home, and when they're in home, they don't text message, and we wonder why we're raising this Facebook, Snapchat, Instagram world where we're wonderful, we're putting masks on things. And I can tell you just the general lack of parenting that shows up, and this isn't a knock on divorce, so some divorces are healthy, but the general lack of co-parenting, the general lack of saying, regardless of what's going on with mom or dad or their children, the kids' lives are better with a healthy mom and a healthy dad. And just that lack of co-parenting that we see. And the part that you guys know all too well and live is when it comes to understanding behavioral health and an absolutely broken healthcare system and understanding, this disease, and ERs are the dumping grounds. And we weren't educated in school. I spoke to a provider the other day that said, "Hey, listen, I was given more education on diseases in sub-Saharan Africa than I was on the disease of addiction." And I've been in front of medical school graduates and said, "How many of you guys have had 1 week's worth of training?" Nobody raises their hand. And so this is still the reality that we live in. And so a lot of times when families come to us and they've been to providers and therapists, you guys don't realize just making a referral to a therapist, you can get your therapy license without ever having to take a substance use disorder class. You don't know that. Like, people don't know that. And that the treatment centers, there's no governance and no regulation. Interventionists, sober livings, all these resources, there's no governance and regulation. And so you guys don't know that. Therapists don't know that. It baffles that it's like the wild, wild west out there. And so when it's talking about the status quo, this is really one of the only parts of healthcare that in 40 years, healthcare is, since the Renaissance when we started creating that, but behavioral health is really only 40 years old, really since Betty Ford, 1960s, 70, when Betty Ford is when money started pouring into it. It's very young, but despite our advancements in technology, prognosis is still the same. Despite our significant advances in technology, prognosis is still the same. And that shouldn't be, because we actually have an enormous amount of evidence of what works. In fact, one of the reasons why I get called around so much is most curriculum is 25 years old, and there's some stuff in here that's a year and a half old. And so we really know what works. And the first thing to understand is even the change that we're seeing. Like I said, it's a different day and age. Gone are the day. I tell parents, also providers, gone are the days of safe experimentation. This is what comes into our offices. And, this is current THC. There was a wonderful article that just came out actually a couple of days ago. THC psychosis in adolescents and young adults is one of the most rising demographics we see. So gone are the days of the hippie lettuce of 15% THC purity. Now we're talking about 99% purity. That is a different drug. It's an absolute different chemical. Like, research chemical drugs is what come into our office all the time now. Like, this comes into our office on a regular basis. This can be ordered off the internet, off of Snapchat, Instagram, legally, FedEx to the parent's house in a nondescript FedEx box within 24 hours. Because the fluoroproposal name, they stay ahead of the FDA. They change a molecule, change it, and it's research not for human consumption. And you can order this legally off the internet from different states. I'm sorry?
It's for pets, I'm assuming.
Pets, research chemicals, synthetic benzos, synthetic opiates. This can all be ordered off the internet in, like I said, from different states, different pharmacies. They'll switch the chemical makeup, make it legal, and then FedEx to their house. And so also, when talking about fentanyl, I go all over and talk to schools where I used to go to high schools. Now I go to middle schools. The conversation also around fentanyl poisoning. It's not fentanyl overdose anymore, because the kids that are dying don't have histories. They don't have mental health histories. They don't have substance use disorder histories. I talked to a parent not too long ago whose 17-year-old experimented with one beer and died because he went to a party and somebody dropped a counterfeit Xanax in the beer, and the counterfeit Xanax had fentanyl in it. Everything has fentanyl in it these days.
So
It
why
is
that these-
absolute. I'm sorry?
So why is it that these things have fentanyl? What's the point if it's just gonna kill people?
No, absolutely, but that's actually that it will kill people because it's so potent.
Right, I mean,
And-
is it just a miscalculation? Like they're trying to get an
It's
extra
because
profit?
it's so fine, and it's done so arbitrarily. It's done in different countries, in a jungle in a barrel.
Right.
and then shipped up here and, chopped up in somebody's living room, and just the slightest miscalculation will kill you. And so it's a great question, and
I mean, it would be more expensive to have a joint with fentanyl in it than just get a joint.
so, no, I listen, and I get that we're using logic and it gets theological, but that's, when we say there's no safe experimentation
Yeah.
anymore. Like, it's unfair, and it's the reality that we're in. It's, and just imagine one drop of that in a vape passed around the party to the unsuspecting, like, those are the kids that are dying. And I used to, years ago, I'd go into the schools, and even here, the largest school in North Carolina, in Ardrey Kell, I'd go in there after they just publicly threw out half the homecoming people in attendance because they were all drunk. It was on the news. And so they brought me in to talk to them, and 30 parents show up in a full of 4,000. And the next night there's a sports banquet. I mean, a sports pre-talk of how to go out for sports, and 3,000 parents show up. It's that's also the reality that we're living in. And but there's no safe experimentation. Like I said, one drop of this in a vape, in alcohol. And so, telling parents and families that it's just experimentation, that's no longer safe anymore. And so what does all this mean as far as, how it affects it physically and somatically and disease oriented, and sort of the pathology that we see is really an understanding in how all of that, environment really shapes the brain and what we know. And so taking us back to med school, we know that the brain is still, in the healthiest of circumstances, is still developing, is still in the cooker till the mid to late 20s. It develops from the, the inside out, the limbic system out to the frontal cortex. And so, the brain is very plastic. It's very influenceable, very permeable in all the stages of development. And we can look back when we have an adult with a mental health presentation, we can then look back and say, we can begin to identify symptoms that started to show themselves by the age of 13. And then by the mid-teens, we can look back and identify 50%. And then by the mid-20s, we can really look back and say about 75% of mental health cases really started to present by the time mid-20s, because that's when the brain is starting to fully develop, fully mature, really reach its maturity state. And I tell people, think about the current day and age where I say there's no safe experimentation. As unhealthy as it was in the 90s, drinking Strawberry Boone's Farm before college or Milwaukee's Beast, as unhealthy as it was, now they're taking those chemicals, research chemicals, fentanyl. I'll go into the middle schools, and I'll transpose the students and the parents will be in small groups with the students. And the parents will be baffled to understand the kids have access to high potency marijuana and prescription drugs than they do alcohol. So where do you think they're getting it from? The parents and medicine cabinets. And even though we've taken away the pain medicine through the Stop Act, their cabinets are filled with benzos now. And one of the most common requests that we get, we talked to a provider the other day that just had a bunch of people on long dose benzos because of COVID and the anxiety. That's actually one of the more abused prescriptions now. And so, think of that brain and how it develops into the mid to late 20s. Just think about even how you grew up and what you experienced. The brain is very permeable. And we know that the earlier the interaction of any substances, the higher likelihood of any mental health issue. And so how does this, sort of affect the identified patient? How did that, what happened to that guy to turn him from somebody who didn't do any drugs, didn't smoke a cigarette, didn't do any of that, actually athlete of the year of North Carolina in 99, to having mental health issues and strapped to a psych ward, in Wake Forest Baptist. We know this disease is a matter of predisposition and exposure. We know it's a matter of genetics. We know there's that, genetic part of it. It also happens on a spectrum. When I go and speak at ASAM, addiction medicine conferences, they tell faculty, don't use the word addiction. It's not in our diagnostic manual. And so it's called substance use disorder. It happens on a spectrum. People don't realize when we say the word addiction, our mind goes immediately to a person on their last day of addiction. We very rarely picture them on the first day. Truth is, 76% of people that have any form of mental health or substance use disorder have a fully functioning job. 76%. In fact, the man who trained me, the vice president of Betty Ford, he was number 2 at Villanova Dental School at the height of his mental health and addiction acuity. And so there's this gross misconception that you're not functional, or it's the junkie under the bridge, or the drunk in the alley, but no, they look like me. They look like you guys. And the part that's actually physically dependent every day is less than 10%. So most people, 76% have a fully functioning job. And so there's that gross misunderstanding of what this looks like and what sort of treatment is necessary. And also, if there's nothing else you take from tonight, just take the next 5 minutes, because this is actually what I'm most passionate about in helping, is this gross misconception of what's needed. And I've actually doing this presentation, I haven't had many providers argue with me about this, but there's this idea that you really have to want it to get better or have to hit rock bottom to get better, and how categorically false that is from our evidence-based approach. And I clarify this for providers and families. And if somebody's going to live a lifetime of healthy living and healthy decision-making, is yes, they're going to have to want it. They're going to have to engage. They're going to have that internal motivation. And in the beginning, absolutely not. And what I mean by that is untreated mental health and untreated substance use disorders are improperly treated. Mental health conditions, 99% of them are just a dysregulation in your frontal cortex of some sort. And substance use disorders, all substances of abuse affect the body differently initially. You have your uppers like cocaine, speed, meth, Adderall. Don't be started on that. That's one molecule away from meth. And downers like benzos, alcohol, opiates. Uppers and downers affect the body differently initially. But in the end and in the long run, all of those chemicals affect the body and the brain the same way. And they shut off or severely diminish the activity in the frontal cortex. And why is that so essential when talking to patients or families or even trying to help anybody? Is that's the part of the brain that affects executive functioning, common sense, decision-making, judgment, reasoning, problem solving, everything that makes us human, everything that makes us individuals, that separates us from reptiles, is in our frontal cortex. That's why parents, we don't eat our young like reptiles do, because we've got a frontal cortex. We may want to, but we've got a stop button, which is our frontal cortex. That's also why the most common statement I hear family members make is, I just want my husband back. I just want my child back. It's like Invasion of the Body Snatchers or Dr. Jekyll and Mr. Hyde. They called me Wardzilla when I was in my disease, because the part of the brain that makes them human is not working properly. Also, we know all of these chemicals are dysregulation in dopamine, the motivation part of the brain. So why would I ever tell a patient or a family member, you have to be motivated properly? The very disease dysregulates the motivation. Or tell them they really have to want it to get better when the very disease dysregulates their brain functioning. It's categorically false. And NIDA, SAMHSA promotes this and shouts it from the mountaintop that when it comes to understanding motivation going into treatment has zero bearing on overall outcome. We think about it, we think about even our most proven medically researched approach about this is behavioral activation. Like, we don't need motivation, we need compliance right now. Like, even if you put, addiction on the shelf, if you think about depression, nobody wants to go outside or wants to engage or wants to take their medicine or wants to go to the gym. But if you force yourself to go outside, if you force yourself to do these things, you can act your way into healthier brain functioning. It's called behavioral activation. And even the University of Pennsylvania, that Ivy League school's medical school, their official motto is send the body, the brain will follow. And so much we try to talk to patients or appeal to patients or their brain is not working. And so it's like, and that's the part that processes language. And so the understanding that you try to talk or appeal or convince the patient is not worth your time. And so an understanding of that part of the brain is not working properly, judgment, reasoning, problem solving, all these things. And we know that. And it comes back, we've actually been able to track where these, we've learned a tremendous amount in the past 5 to 7 years and how these chemicals affect the ventral tegmental area and that limbic system, and just shuts off all judgment and reasoning and problem solving. Even when they become chemically dependent, not necessarily behaving addictively, that frontal cortex is not working properly. I mean, look at this image. That's the horizontal image of somebody's abstinent. That's somebody 10 days abstinent. That's somebody 100 days abstinent, like after they've done a 90-day treatment plan. And I asked providers, parents, families, would you trust anybody to have any influence over your life or death medical treatment plan with that lack of cognitive functioning? Then why do we allow them to have the influence over their own? And so one of the things that we do is, when we track outcomes, we know that people stay in treatment with us twice as long as the national average. And, parents always ask, well, what's going to make you guys so different? I said, it's not a mystery. We treat this just like any other disease. We take the medical decisions out of the non-medical professional hands. It's the only disease in the world where we tell families you have to wait till the highest level of acuity, the highest level of severity before you do anything about it. The only disease in the world where we tell people you have to hit rock bottom. And would we treat that with any other disease that you guys see, like cancer? Like I know we caught it early. I know we caught it stage 1. Why don't you go back out there? Don't worry about taking off work or taking off school. Maybe lay in the sun a little bit. Come back in here when it's really difficult to treat, really complicated, really inconvenient, really costly, really deadly. And maybe it's time to do something about it. This is just like any other disease. The earlier the intervention, the earlier the prognosis, you follow the professional's results, then the higher the prognosis. And you have to want it to get better. Guys, this is a healthcare crisis. I mean, that was me 2 years ago. What happened to me was when I was 18, it was the day before I was supposed to report to Dean Smith's office. It's Friday the 13th, 1999. I remember it like it was yesterday, that I was diagnosed with a rare autoimmune disease called relapsing polychondritis and given 2 years to live. 87 surgeries later, and they pieced Humpty Dumpty back together again. And so that was at the height of the 90s of the OxyContin push. And this has been just a couple of years ago. And not one of those surgeries that I want. That's chemotherapy and radiation suck. They're inconvenient. They're costly. It's unfair. They have every right to be angry. And it's still the appropriate path to save their life. And so the understanding of this is just like any other healthcare crisis, and yet we'll throw it at the family's feet and say, you Google WebMD, you Google a treatment center that's ungoverned and unlicensed, and you figure it out. And it starts to make sense why prognosis hasn't improved in 40 years. I mean, when you look at dual diagnosis and depression and substance use disorders, 50 minutes once a week at a therapist's office, or 30 minutes once a month at a psychiatrist's office that doesn't measure or look at the organ they treat, and that's going to be effective. So it's grossly mistreated and misunderstood. And we try to appeal to the identified patient, and the drug of choice doesn't matter. It's all substance abuse, like I said, affect the body differently initially. But it comes back. The treatment, it absolutely comes back. That neuroplasticity comes back, the retraining of the brain's pathways. But it takes every bit of 2 years to stabilize this. And if you think about any sort of severe progressive illness, what doesn't take 1.5 years, 2 years to stabilize in a family system? And so it takes every bit of that. And for the first year, 1.5 years, it needs compliance. And you wouldn't trust that brain. And a lot of people ask about success rates. First thing I'll tell them, because I think it's important to understand evidence-based, because we know what works. When we talk about success rate, any treatment center or professional that tells you a success rate to the treatment center is lying to you, because we haven't figured that out yet. Like, what is a success when you talk about data and research? If somebody goes through a spectrum of care, stays stable or sober for a month, but then has a mental health break, or then has a reoccurrence, is that a success? Or at what point do you judge success? So we haven't figured that out yet. But there is one demographic we know very, very well: doctors, lawyers, pilots, nurses, those patients with licensure or responsible for public safety. We work hand in hand with Joe Jordan in the North Carolina Physicians Health Program and the Legal Assistance Program, the diversion programs that your colleagues have to enter. We work hand in hand all the time. And we know that if you're a physician, the North Carolina PHP, you have to enter the diversion program for 5 years. You have to comply with treatment, and you get drug tested once a week plus 10%. For the tricky doctor that thinks they can drug test on a Monday, they have a week to do it. There's always a 10% chance you can test the next day and the next day and the next day. And so we have data sets for 5 years. And of all that professional community, the success rate is 90% at the end of 5 years. 90%. And the general population, 7 to 14%. And that shouldn't be, because I can create the same exact treatment plan for the same individuals. One will have a 90%, one will have a 7 to 14. A lot of people will say, well, that's because they have a high priced career over their head. And I said, no, same statistics true for the stewardess that makes $30,000 a year, the dental hygienist. The only controllable difference, and this is really important, is family. The only controllable difference is family. And what I mean by that is Dr. Joe Jordan forces the treatment plan on the doctor or but regardless if they're motivated, regardless if they want treatment, regardless if they admit they have a problem, regardless of what the family says, you have to comply in order to get your license back. 90% success rate. And over here in the general population, I'm entirely dependent on getting the family what we call a sphere of influence and educating them with this information, usually in the first 30 or 90 days, because that's when the patient is in some sort of inpatient before they get out, that their brain isn't going to work. And you actually have to hold boundaries as best as possible to force compliance. You don't never have control, but to force compliance for long enough for their brain to heal. And let's just be honest, after 6 to 9 months of that, it just gets, when a healthcare system isn't set up to, it gets exhausting. They get treatment fatigue. And they get a treatment system that says after 28 days, you're on your own. And so they don't have a professional that says, we're going to guide you through this the entire time. And we're going to make the decisions, even when they're out of treatment and they physically look good after 90 days, cognitively, they're not even close to being there. Still not the time to listen to them. But as a family, it's hard to hold those boundaries. I mean, even as professionals, they tell us you can be the greatest specialist in the world. You still cannot treat family because you can't see them accurately. And so being the professionals that lead this in an outpatient, so we have that long-term relationship because the brain heals through consistency, not intensity. That's how neuroplasticity is. And so what makes us so different is family-focused care is mandated. It's not optional. And so the family has to be in there and has to do it too. And we begin to make the treatments and we educate them about this. Like even in our reference to understanding relapse. Listen, I don't believe in the vernacular relapse is a part of recovery because it's not. It's often part of the change process, but we don't even use that vernacular. You know, we call it a reoccurrence. I mean, the whole thing is all that we approach it is much more disease oriented because it has the same relapse rate as asthma, hypertension. My autoimmune disease is called relapsing polychondritis. Like we don't expect our patients to be perfect. Like the goal is perfect abstinence. I said that's just grossly ineffective. We hope for it, but you know, help for people to understand that it's much more than just about abstinence. It's a general quality of life and general sort of well-being. And so, you know, as we, you know, sort of close in understanding is like really this disease that is in all of our offices, whether we directly have diagnosed it, whether the impact of it, whether it's the ripple effect of it, or whether the idea of even the family members who have the chronic stress, because actually part 2 of this lecture actually shows you that the family member's brain, actually, they don't have a frontal cortex either because they've got chronic stress all the time, that adrenaline and that cortisol. Said my mom called my house every morning at 6:30 when I was at the height of my addiction, 6:30 in the morning. And when I went through this process, I tell people I thought she was just being that helicopter mom that she still is, you know, but I went through this process. She was just calling to see if I was alive. And by that time, in 7 treatment centers and psych wards and the height of my disease, I had valid reason to wonder if I was alive. What other scenario other than having a loved one deployed to war, and I'm not comparing war and this disease, but do families have mortality level stress day in and day out, that adrenaline and that cortisol in their system all the time? And what do we know about, you know, chronic stress and that adrenaline and cortisol in somebody's system? You know, their body begins to malfunction. And we start to begin to understand why when any family has a progressive disease in it, family members are 5 times more likely to be in the hospital. And all too often, you know, we don't understand what's really, you know, going on there. And so they go through a parallel process. And so when the healthcare system says, either tries to talk to the patient without a brain or the family member without a brain, we understand why the prognosis hasn't improved in 40 years. You know, that's why finding a professional, and believe me, I understand when when I say this, find a trusted professional, and then I say 98% of behavioral professionals don't know what they're doing because they haven't been educated. That's the unfair reality of this. Is when I go in, this is new information to addiction and mental health professionals and psychiatrists when I go in there. And that's why just referring them out to to a therapist and just random treatment centers. That's why there's no better prognosis. And this is the reality that we're sort of left with. That's why families sort of enter our office, what I call trauma bonded on the identified patient. You ask them how they're doing and they'll answer you what they know about their sort of identified patient. I was a part of a study years ago that studied family members' brains because we call it a family disease, but we wouldn't really translate that into pathology. But we know that family members' brains becomes their dopamine trigger. They crave it just like substances. And so what the family member wants often is just as unhealthy as what the patient wants. In fact, if you ask most professionals in our field, they'll tell you that when treating this disease, the family is the number one barrier. And they're not intentionally trying to sabotage the process, but they aren't educated and the healthcare system hasn't helped them. But that's what a family member's brain looks like. And that image just came out about a year and a half ago. And this is a family member that actually followed our recommendation for 2 years and wanted to didn't. Because time doesn't heal all wounds. When it comes to anxiety and stress, you can step aside and still work yourself up. It still has the same impact on the body somatically. And so you actually have to do the work. Time doesn't heal all wounds. And so when we say that we include the family and they're required to do these things, they're required. We even give it away for free because insurance companies don't pay for it. We give away free community workshops. There was 250 people attended our last one last weekend. And we actually give away professional CEs free too, just to educate the community on this. Because we know that treating the family is the only way, properly treating the family is the only way to evidence-based approach this. And so if you were to put that next to each other, you can understand why the patient and the family, they say they go through a parallel process. Their brains are about the same. And yet we'll throw it at their feet and tell them to Google WebMD and you make the treatment plan. And we tell them, it's not your fault. You're actually trauma survivors. Like when you have a loved one that goes through this, you're trauma survivors. They're not codependent or not enablers. They're trauma survivors. And they've got PTSD symptoms that, sort of need to be treated. The only difference is, we'll walk beside them the whole time. And, that's sort of what we do. And I'll tell you that this is the best image that I can show you about what we do is, outpatient care, we know, is step down treatment that's driven by American Society of Addiction Medicine, sort of ASAM standards, evidence-based standards that aren't required to be used, is, if we have outpatient that's 5 days a week all day, and then 4 days a week, and then 3 days a week, and then 2 days a week. And so it actually steps down as their brain becomes back more online. Everything we do is followed by, evidence. And that's why the brain heals. That's why more group support lectures, as their brain heals and frontal cortex comes back online, they're more individual work, but all during this, it's all done by evidence-based reasons. And you can actually see why you can't measure success, but you can measure symptoms, why people stay in treatment with us twice as long as the national average, because we have that family in that forces compliance and they don't have to do it alone because we're with them. And so we know when people remain in treatment twice as long as the national average, we know they get better. We work with medical communities. We have an outpatient detox now that when people get stuck on opioids or benzos and just chemically dependent, detoxing them in the comfort of their own home. It's more individualized. We know that sometimes people are working, so you need to flex that schedule, and so, we offer that, true, individualized care. I mean, it's one of those things. When I moved back to North Carolina in 2016 and opened up, the Blanchard Institute, at the time, there was no progressive dual diagnosis treatment center in the entire city of Charlotte in 2016. And so, when it comes to understanding this disease and the resources, it really is about understanding that trying to convince the patient, don't get me wrong, if they're motivated, it may be easier to get them in, but long-term prognosis has no bearing on that. It's really about get into that family and, teaching them that they're the ones that, get even running the admissions say, and I've done clinical interventions for 15 years and never had the power of the state to take somebody's civil rights away. Nobody wanted to go into treatment. But as long as the family followed our recommendation, we always checked them in. And so it's a much more complicated process, and especially when it comes to the healthcare system and it being ungoverned and unregulation, it's tremendously sad and unfair. And it's the reality out there that, they don't know what they're doing. And so, I know it's like, drinking out of a fire hose a lot, but I'd love to hear what you guys see and experience, and raise your hand.
Is there any movement to try and get or require some of
Yes.
these therapists, like to be?
It's actually a great question. I sit on a board of AP and NC addiction professionals in North Carolina. And we submitted legislature that mandates insurance companies to use ASAM standards, American Society of Addiction Medicine, 6 dimensions, that mandates insurance providers and professionals to do it. And Blue Cross Blue Shield's lobbyists shot it down. And so, and we've, but there is a movement to try to do it. I can tell you that most treatment centers worth their salt, which isn't many, use that. We do have accreditation. You either have Joint Commission or something called CARF. You have to have one other. We actually have both, not required, but we actually have both, just to show that we try to keep ourselves to the highest level of accountability. And that's not being, a saying. It's the fact to try to show some level of accountability. There is, it's a hot topic of conversation, especially when you start talking about even things like sober livings or interventionists that are even far more ungoverned. But the actual that anybody, I tell any parent, you can apply to the DHHS tomorrow and get a license to run a treatment center. You can't do that with general health care. I can't, I'm not an MD, I can't own a doctor's practice. You got to get approved by the North Carolina Medical Board. That's not the case in our field. And yes, sir.
I have a question, when we renew our credential with hospitals, always they ask, do you have a problem with the drugs? And I think professionals probably are afraid to say yes, because that has significant consequences. I think this question should be dropped, honestly, to renew credentials for doctors, so they can be forthcoming and come to the professional.
Yeah, and in fact, actually, the most common request that we get after these conversations is to go into y'all's private practice and to teach you how to have these conversations. Because also if you think about just the neuroscience impact of not having a frontal cortex, it steals their self-awareness. And so that's what that means. And so I tell families, it doesn't mean that they're intentionally lying. I compare it to when I was a lifeguard at the Outer Banks, and we went out into the, every summer they train us when we go out to save a tourist that's drowning in the water, we ask them not to swim in, that they'll try to drown us. They're not intentionally trying to murder us. It still feels like that from the lifeguard. Very similar, the patient's limbic system's kicking in, and they'll scratch, claw, lie, cheat, steal to get to the top. It doesn't mean that their character is a liar. You still can't trust them if you're the family member, but intent matters. And so they don't answer the question very accurately. I mean, when we even have identified patients, do the assessment, it's amazing how much is revealed by the time the first week they're sober and by the time they're 90 days in. And so, and just imagine that if you're a psychiatrist and the only self-report you have is from that person whose brain isn't working, and you diagnose somebody bipolar, it's like where they're coming off of meth and Xanax, I'd be a little up and down too.
Mm-hmm.
And so, or the even beginning had a primary care doctor was trying to help that met a child 6 years old that within 30 minutes of meeting him, diagnosed him with ADHD and prescribed him Ritalin. 6 years old. It's like, really? And but that's what we see. There's just not a appreciation or understanding for the brain, how it heals. And I'm not anti-medicine, believe me. And I don't think we should be martyrs. I help people with chronic pain because of what I go through, and I don't think they should be martyrs. They're absolutely an appropriate place for those things.
Do you feel like, you mentioned dopamine a lot, I mean, even in depression, anxiety, there's were those all scans we have to see with people with substance abuse, or about depression, anxiety? Is it the same thing with
Yeah, one of those scans with depression was
Right.
just pure depression.
So you mentioned dopamine a lot. I mean, I feel like, is that something that is missing? I mean, in our, people are taking so much supplements, so much vitamins. Oh, I don't want medicine. Well, is that something to start talking to patients? I'm like, And wasn't, I mean, if this is true or not, wasn't lithium in our waters many, many years ago naturally? I don't know if that's true or not, if I read that correctly.
No,
You know, I mean, a form of lithium or something like that, and now it's, you know, obviously not. I don't, is that true or not?
no,
First
look,
of all?
you were getting ready to ask about the dopamine. I actually have a slide about dopamine that this is really a 3-hour lecture,
Oh, wow.
sort of about dopamine.
Right,
And,
yeah.
because, listen, dopamine is sort of what I call society's nemesis. It what motivates us. It what helps us. I tell people, like, how many of you guys are to-do list makers? And what happens when you do something during the day that at the end you'll write it on there just to cross it off because we like the dopamine. And,
Right.
you know, when it gets out of balance, you know, gambling, sex, work, all this, there are actually age limits on everything but social media, which is dopamine driven. You know, Florida actually just promoted this law to actually have age limits on, but dopamine, you can trick your brain into thinking you need something to survive.
Mhm.
And when it comes out of balance, you know, dopamine also regulates, you know, sort of the oxytocin in the frontal cortex. And so when dopamine is out of balance, you know, your frontal cortex is out of balance. That's why they think dopamine addicts are sociopaths, because their frontal cortex isn't working, and that's empathy. And so that's where the oxytocin is. And the truth of the matter is that there's another slide that says, you know, oxytocin is really mental health and substance use disorder inhibitor. And that's more long-term. It's that trust, that love, and from a vulnerability, not from a psychobabble point of view, but from a biology point of view. We need that. And it's not individual therapy without somebody without a frontal cortex. Listen, individual therapy can help in the beginning, but it's grossly ineffective until a year and a half, 2 years in. But group therapy, compliance, that's what makes people uncomfortable, but it's still required. And so that oxytocin is what, you know, comes back. That long-term is the difference in dopamine. Not what I tell different of sex and making love. We all know what that means. One is much more long-term, takes a while to develop it. Like when you walk into a small group, you don't feel safe, secure, and connected. But as soon as you do, you'll get up and do it. And even 12 steps in community support. Like we don't, I love when people want to argue the difference, because there's no difference in 12-step, Dharma recovery, celebrate recovery, smart recovery. We offer them all. They all say the same thing. Can't do it alone. You got to come consistently, and you need a mentor or sponsee. And it's all based in neuroscience. There was a doctor that I put in treatment a long time ago, and diversion program, and he was forced to go to meetings, and then it worked, and he wanted to know why. So he wrote this wonderful book called Hijacking the Brain, the Neuroscience of the 12 Steps. And a lot of people say it's spiritualness, but it's all based in sort of the balance of endorphins, dopamine, oxytocin, and serotonin. I mean, it's all, you know, sort of based in that. And we know that it works, but dopamine is a huge part of our overall society's issue.
I do neurostimulator implants. They want us to do a psychological evaluation to see if they're, I mean, I'm trying to give you a clinical scenario too. So these people already have comorbidities. 50% of my paying population have some kind of psychiatric comorbidity.
Mm-hmm.
And my success, we put in an expensive device in them. So we're doing a trial for about a week, and then these people are already fixated on their pain level. But the challenge for me is we have 7 days for them to evaluate and then see if my pain trial, modulation trial gave them benefit. Now, if in their mind, they already are fixated on a pain score of 8 or 9,
Mm-hmm.
it gets very challenging for us to bring them down to 4. And do you know any ways which how long does the neuroplasticity take even with the reduction of pain?
Yeah, no, it's a great question. And I can tell you, especially with chronic pain, there's a difference between pain and suffering. And 7 days without proper clinical support is going to be very difficult because of what you just said. And but when it comes to specific chronic pain, we know that when helping individuals, that's also an element of a sort of a brain disease, and helping them clinically assess the difference between pain and suffering. It's amazing how much pain I can deal with when I'm a little bit healthier, centered and not hyper focusing like you described. And I would say it's very difficult to get that pain scale to come down, inside a month.
Yeah, but the challenge I have is they are so fixated
Yeah.
on the number for so many years. And it's amazing that they are afraid to even say it's below 5.
Oh, and it's actually, and so chronic pain patients, anytime that you taper them off, and listen, I want to be clear that I don't think that we should be martyrs. And like I've had many surgeries, that surgery that was supposed to be 3 hours ended up being 12 hours. I had pain medicine with it, but there's appropriate ways to do it. But there's but we also know when people are coming off of chronic pain, they'll have hyperanalgesia, they'll have rebound pain.
And no, here's the thing, I don't stop their medications too. The psychological aspect of them to acknowledge that their pain score can go below 5 is so hard. They don't even want to acknowledge that it's below 5.
Oh, absolutely, 100%. It's all psychological.
Objective
Yes.
scale, and I wonder, like, are we on the suffering line, or are we on
You're-
really nociceptive?
You're on the suffering line. And I can tell you,
That's what bothers me, like,
I
so
can't-
if my treatment is related to score and percent, how much, and the insurance only give me an option one time to go put a trial on. It's amazing with looking at your study and then all this functional MRIs, how much am I really nociceptively treating the pain?
in 7 days in those trials, I can tell you not much.
Yeah, I was wondering, like,
Sad, I mean, it's all insurance based and acute based. It's just kind of like, we got a patient now we're intervened on that active psychosis that they put them in a Wake Forest Davidson, hospital systems are, acute care only, that 3 to 7 days. I've had a patient sitting in the discharging psychiatrist office, actively hallucinating, saying, do not discharge him, and they discharge him to once a week therapy. And so it's all acute based, even insurance, it's all acute based, medical necessity. And with what you're talking about, chronic pain, it's a combination of medical necessity and clinical necessity, but they don't recognize that component of it. And so in 7 days, there's such a psychological aspect of getting that pain score down that there's no way to really reasonable get that patient to acknowledge that. But we have intentional, like chronic pain, actually workbooks and tools and activities that we get. There was a lady named Pam that came in just on tremendous amount of opioids. Never thought she'd come off of it. Never thought she'd come off the benzos, the Valium. Never thought she'd be able to sit in group. And now she's, 8 or 9 weeks in. She didn't think she'd complete our outpatient detox. But just the process of psychologically helping them so they don't feel like they have to do it alone is not psychobabble. I mean, it actually tremendously helps them because they're also scared you'll take their pain away, take their pain medicine away, and they'll always be in pain. I mean, there's so many catastrophic fears that with rebound anxiety or hypoanalgesia that need to be accounted for that you can't do in an untrained setting. That's actually why we created our, sort of withdrawal management outpatient detox and the clinical process that people go into really as a result of all the things that you just said. And so I know you had your hand up too.
Questions about marijuana.
Huh.
You can't really walk down the street anymore without smelling it. People are smoking it all over the place now. It's just kind of becoming more pervasive in our society. I think there's a lot of downsides about it. I don't know. I think THC in North Carolina is actually legal, even though marijuana itself is not legal. I know different states are legalizing it. But what is your feeling on that? I mean, do you think we should, as physicians, push back against this?
I actually really appreciate that question because I spent most of my first part of my career in California, in Southern California, even in Colorado, and speak on that here. And there's a couple feelings about THCs. First, it's just that you may not have been here when I first started doing it. When I started talking about the 98-99% purity, we know that THC and psychosis in adolescents and young adults is the most rising demographic. And so when talking about THC, I can tell you that just go ahead and accept it. It's going to become legal in every state in the country. That is a cost savings measure. It has nothing to do with how harmful it is. Percocets are legal. Budweiser's legal. They still become addictive and harmful. But THC is going to become legal in every state in the country, and it has nothing to do with how harmful it is. It has everything to do with the government saving money to not have them be in prison. But it's going to be legal in every state in the country. But it's very harmful right now. And could there possibly be some some medical benefit, and the jury's still out. I know that and I know this, there's a significant amount of research in Colorado when it comes to, well, it'll take the place of all the opioids. Listen, there was more overdose deaths in Colorado than just about anywhere else, and more THC ER visits than anywhere else, because it didn't take the place of it. It was a partner drug, and actually made things worse. And so it's still very early on. Do I think that there's progressive things that we can use appropriately? Like when I was at the Mayo Clinic, instead of loading me up full of Dilaudid, they did have a little ketamine drip that was appropriately done. You know, there are some appropriate, whether it's, ketamine, is there going to be some possible benefits in the future? Maybe, but we are a long ways away from that. And anybody that says that it's legal or illegal, that doesn't matter. It's still, like Percocets are legal and then alcohol is legal. It's still very harmful, and it's really not calculated in a pharmacy. I mean, it's really done in the street, and now fentanyl's in it. And so adolescents and young adults, and even with alcohol, I tell parents, I said, I know there's some parents that say, I want them drinking in my house. I said, before they're 21, I said, not only is that teaching them that they can break the law as long as it's okay with you, but we also know that earlier that any sort of substances, the higher likelihood their mental health issue is. And that one 17-year-old that experimented with one beer and died. There's just that ways there's no safe experimentation out there. But with THC, it's actually being rammed down our throat, legal and illegal. But make no mistake, that is a government cost-saving initiative that has nothing to do with how healthy or unhealthy it is, or how medically appropriate it is.
The THC treat pain, just curious, I mean, is that is conflicting data on it?
Exactly, like that's what they thought would happen in Colorado, is that it would treat pain and take away the overdose deaths and take away, and it actually increased them because it was a partner drug. And so, is there going to be some level? I've read plenty of studies where there's a certain type of cannabis that they take the THC out of it that helps with seizures and chronic pain. But most of the people that you talk to say, no, I want the THC in it. It's like, yeah, because that's because you want the high part of it. Because actually the medical benefit of it is actually the other stuff, not the THC. And so when you hear people argue for the THC, it's like, well, that really doesn't have any medical benefit. And so when you hear that argument, then it's just about recreation.
So, I have a teenage son.
Mhm.
Social media and obviously porn is also gonna play into that. So, what do you recommend for middle school? I heard you say you were in the middle school.
Lock him in the basement until he's about 25.
So how, as a parent, how do we like really give them that prefrontal decision making, or you can call it like, I can only tell them.
Yep, no,
it's a porn.
So I was having this conversation at a podcast with a dad not too long ago, and he said, Ward, this is really hitting home. I just have a 3-year-old a daughter and a 4-year-old son. How do I be a good dad and have this not happen to my kids? I said, the first thing you need to realize is you can be a great dad and this still happen, because this is a disease. Would you say that if it was cancer, or you can't be omnipresent, but you can be present. And so that's where I think families have gone wrong. That's when I talked about what's the real issue, is you have to be very present and borderline intrusive because of the current environment. And so you actually have to have those difficult conversations of, no, you can't do that. That computer's going to be out here. And also even with marital issues, as a marriage and family therapist, it's amazing how many coupleship problems would go away when I say, you guys leave your cell phone out of the master bedroom past 7:30 p.m. If you want to take a call, absolutely take a call, just take it outside. But in the master bedroom past 7:30 p.m., no phones. It's amazing how many marital problems go away. It's the same thing with it. If we can't control that. And also I tell adults that if, there's an old anecdote that's like, if the last thing you think about is a drink before you go to bed, and the first thing you think about is a drink, you may be addicted. Well, if the last thing you look at is your phone, and the first thing you look at is your phone, and you walk from room to room with your phone, you might be addicted. And there are people that will detox more from their phone when we take it away than with little substances, because it's dopamine driven. It's actually, like I said, Florida just started proposing a law against social media past 16. because it's called the gamification of technology. They actually went to Stanford Institute of Persuasion to learn how to do that. They learned how to hack our brains to create those things. And so they actually preyed on our most human vulnerability. And so to get us wrapped up in that. And so we know it. We love the buzz, the ding, the trauma of being unfriended, the amount of likes we get. You know, we have it too. And but to be present and engaged, you know, actually, I was in a medical office. I was actually talking to the technology officer. Most tech officers, my brother owns his own technology company, are super strict with their kids and screen time. Like it's because they know how damaging it can be. They know how healthy it can be. It's like ADHD diagnosis has increased 75% in 10 years. That's a frontal lobe disorder. Do you think 75% of frontal lobes just stopped working? Or do you think this is the first generation that we put screens in front of them since they were born? And the distraction that they don't know how to be. There's a difference between being distracted and inability to focus.
Do they recommend any norms of the screen time?
Depends on how old they are.
What kind of boundaries do you create?
Depends on how old they are. You know, if they're younger than 13, you know, very limited. You know, if they're really younger than 16, that you know, social media at all is pretty harmful. There's not much healthy that can come out of it. And so you know, extremely limited until after 16, you know, because they're going to get some of it at school and proper interaction and just in the stream of life with screens. But would I allow a 13, 14, 15-year-old to have a screen, computer, and iPad in their bedroom for hours and hours? Not these days. And it's unfair. That's what I tell teachers when they're like, when I say their parents aren't home, I said, well, that's unfair. I said, and it's the field you chose right now. It's like, we can talk whether it's fair or unfair later. That is the reality that we're in. Just a different conversation.
No, I'm asking, is there any screen time norm which any of your societies?
There's some I mean, I have some information. I'll be happy to send you on that,
Yeah.
that it's actually for developmental psychology, like when you're 12 or 13 and below, like really limited, you know, 12 and 13 to 16, maybe a little bit more, 16 and up. Maybe it's appropriate to have certain elements of social media, not before 16, but I do have some of that. Be happy to send you. Absolutely, that you know, that information. And I can tell you guys, we one of the most common requests that we got even during COVID is Chamber of Commerce's to talk to businesses about this impact in their businesses and just people that would never having mental health issues before, finally having substance misuse issues or mental health concerns pop up. Even in your own employment, I can tell you 1 out of 4 people have this going on in their home. And so, you know, even we do things, whether it's coming and educating employers of how to even create a mental health safe workplace to have conversations about, just from a humanistic standpoint, but also from a bottom line standpoint. And unhealthy people cost you a lot of money. But also from a practice, I was telling Charlotte when we talked to her last time, the amount of the doctors that asked us to come in there and talk to them about how to have these conversations, nurses and, you know, other providers. Like once you've identified somebody may have a problem or on the CSRS and they may have doctor shopping, like even as a provider, you can talk to somebody about diabetes, but going in there and talking to them after that, it's just uncomfortable. And so how do you talk to them, you know, sort of assertively, you know, in a helpful way without just throwing them a flyer and saying, get out. That creates, you know, what I call opioid refugees is, and it's harmful. And so, you know, figuring out how to talk to them, how to engage them, you know, bring the family in is really, when you're talking about it, the oath to do no harm is what, you know, should be done. And we go into, and we do that voluntarily and, you know, happy to do that and have any sort of conversation. And I can tell you guys that if there's anybody in your office, my cell phone's on my card, you know, this guy picks up all the time. And we can place them, even if it's not with us, we can place them. We actually also have, you know, access to nonprofit funds because, you know, indigent people can often qualify for state funds. Wealthy people can afford it, but the middle class is who's dying. So the parents, a UPS driver and a teacher that have good insurance that can't afford the $6,000 deductible. You know, they're the ones who family members are dying. And we have access to resources, vetted resources that are cost effective. And I promise you that if there's a family that's willing to do whatever it takes, regardless of the patient, as a reasonable guarantee, I can find them resources somewhere, cost effective, no matter what they have in their pocket. And so we'll take the call, no matter if it's with us or somewhere else, and make sure we get them where they need to go.
Yeah, I reached out to you on Facebook. It was about 2 years ago.
Yep.
I had a neighbor that her daughter was a veteran. And she showed up that her significant other had beat her up, drugged her up, but she was feeding her mom so many lies. And like, I could see through it all, but the mom, oh no, this has happened. And she ended up taking her to Atrium. And within a week, the daughter had convinced her mom, I'm all better now, bring her home, And it was just so frustrating because the mom needed the education.
Yeah.
She's the one that needed.
Yeah, we'll focus on that identified patient, and even HIPAA will protect it. And we actually do the opposite. Actually, when we have our clinical meetings, when it's time for patient intervention, I say you first talk to the sphere of influence. So how can you possibly worry about how that patient's going to respond when they're spending 20 hours in their family system and knowing how you can set your, so we actually require, just like with, before we start giving updates to family, they have to come in and come to our groups. It's mandated. I mean, we offer, like Thursday nights, we offer a free professionally facilitated support group every Thursday night on Zoom. It's right there from 7 to 8 p.m. Anybody in the community can open it. Atrium and Novant's providers actually sometimes will come in and observe. They go into our Lake Norman facilities, sort of observe our practices. A lot of their residents and family practitioners, because they know it's going to infiltrate into their practice, but we give away a lot of free professionally led services. Community support groups are great for families. We're huge supporters, and you can get a lot of disease, a lot of inaccurate information in there. And so you need professionals to guide the conversation. And so we provide, because insurance doesn't pay for it. And so we just provide it for free. And we provide a lot of open to the community professionally ed resources. And like I said, that Thursday night, 7 to 8 p.m. group, a lot of times I'm on there running that group, and it's enormously helpful to parents and any sort of family member or sphere of influence, figuring out how do I do something about this.
I wish the hospitals would really take that and kind of integrate it in, because they're the ones that are, a lot of times, we can tell people about you, but they're gonna go to the major players pretty much.
Oh, yeah, yeah. But I very much, appreciate the conversation and the questions, and happy to answer anything, and, sort of anytime. Like I said, my cell phone's on my business card, and get calls all the time about how to handle, where to go if I've heard of this person or that place. And same with Michael, especially when it comes to helping with tapering people off some of the medicines. And we are, make clear, we are not anti-medicine, but there is a little bit of overabundance. And how do you properly get somebody off when they have the clinical support to help them, navigate some of the psychological and the rebound medical, anxiety and pain, with that as well. So thank you guys.
Thank you. What do you guys have again?
So we actually have
Any questions online?
right there off of Park Road Annex, right by Atrium Pineville. We have 7,000 square feet right there. And we actually have